Welcome to our evidence-based practice video presentation. My name is Gabby and I did a critical appraisal of one of our articles.
I'm Catherine and I do a brief summary of the articles and I synthesize the evidence.
I'm Monica and I'll be doing an overview of our literature search criteria and be providing some recommendations based on the evidence we found from our studies.
I'm Sandra. I'll be going over the nursing problem, the PICO question, and the conclusion. For our research project, we all found that we had a mutual interest in critical care patients. As we discussed past clinical and work experiences thus far in school, we all agree that nurses, doctors, and all other hospital staff are constantly flooding patients' rooms. Does this loud environment affect patients' mental states? How does this noise affect patients in ICU settings at risk for delirium? After realizing that we all agreed and felt strongly on this subject, we formulated our PICO question. Our PICO question is, are adult critical care patients who have experienced hospital-instituted quiet times at a lower likelihood for delirium compared with those who have not experienced quiet time during their stay in a critical care unit? This type of question is foreground versus background, and the type of template we used was an intervention, therapy, prevention.
To find our studies, we used Galileo as a portal for the databases CINAHL+, Medline, and PsycInfo. Using only the search terms quiet time and patient outcomes, we retrieved an initial 143,842 articles. Following the literature search criteria table, we narrowed our search. Adding the search term nursing yielded 43,516 articles. Limiting the year range of the articles to between 2012 and 2016 yielded 13,762 articles. Adding the search term ICU narrowed the article number to 1,748 articles, and applying the limits of English and peer-reviewed articles brought us to 1,465 articles. Adding the term delirium narrowed the results to 545 articles. Adding the term adult narrowed the results to 459 articles. And a final search term of critical care nurse yielded a very manageable 50 articles. From this search, each group member selected 2 articles of the most interest and relevance for a total of 8 articles. We selected those that were most relevant to elements of our PICO question, including the applicable population and setting. We were looking for our articles to be both clinically significant and coming from credible sources.
The most influential articles we found were articles 3, 4, 5, and 7 in our findings table. Here's a brief discussion and summary of each. The third article in our findings table was a prospective study that used a convenient sample of 72 patients on mechanical ventilation that were over the age of 18. They were in a medical ICU in the United States. This study looked at the effect of quiet time on patient sedation frequency, delirium scores, physiological measures, and the nurse's perception of their patients' sleep patterns. The findings suggest that fewer doses of sedation in 24 hours were used after quiet time was implemented. Patient agitation decreased and patient experienced goal sedation after quiet time implementation. After 3 consecutive quiet time intervals, there was a significant decrease in respiratory rate, as well as a significant increase in nurse satisfaction. The fourth article in our findings table was a prospective cohort study. There were 57 pre-intervention participants and 66 post-intervention participants. All patients were greater than 50 years of age and received treatment in a surgical ICU in the United States. This study looked at incidence and duration of hospital-acquired delirium after implementing 2 90-minute quiet time intervals per day. The findings of this study included consistent incidence of delirium, but significantly decreased duration. Patients also experienced fewer days on mechanical ventilation, shorter surgical ICU stays, and a lower dose of benzodiazepines. The fifth article in our findings table was a randomized control trial that included 69 patients in the intervention group and 67 patients in the control group. The mean age of intervention group patients was 57 and the control group was 62. The study was conducted in an ICU at a Belgium hospital. The researchers were attempting to determine the effect of earplugs on reduction of delirium or cognitive impairment on these intervention patients. The conclusion was that earplugs reduced cognitive impairment in 43% of patients. The most beneficial effects of earplugs use were seen within 48 hours after admission. The seventh study in this findings table used descriptive statistics and quantitative content analysis to determine the relationship between sound and the occurrence of delirium. This study was conducted using 13 patients in an ICU located in the United States. The findings of this study suggest that negative noise, such as staff talking, noises from machines, sick patient yelling, created negative feelings such as fear, hopelessness, and anxiety. The main conclusion of this study found that high noise levels do interfere with sleep patterns and patients' overall emotions and satisfaction.
We determined as a group that article number 2 in the findings table was the most important and therefore the one we would choose to appraise. I will now go through and list the different elements of the appraisal and what our overall thoughts were on the importance of this particular article. The research question was to examine the influence of quiet time in critical care patients. The purpose of the study was to determine if quiet time intervals had a positive influence on patient outcomes. The sample was obtained using convenient sampling of non-randomized adult patients from a neuroscience ICU as well as a cardiovascular ICU. The inclusion and exclusion criteria used were as follows. There was a convenience sample taken of 199 patients, of which only 129 patients were used. These patients were both male and female, age greater than 18, and English speaking as their first language. It also excluded patients if they received general anesthesia in the previous 8 hours or at a Glasgow Coma scale of less than 10. The sample of participants included 129 patients that participated in 205 quiet time intervals. The methods used to collect data were a one-way repeated measure analysis of covariance. This was calculated compared to a Richards-Campbell sleep questionnaire scores, pain, and anxiety over consecutive quiet time intervals. The intervention tested was to reduce environmental stressors, and patient rest was promoted among the nursing staff. The sample size was determined using a power analysis, and patients were not randomly assigned to treatment groups. There was no statistically significant findings, but patients did report sleep levels higher and anxiety levels decreased over consecutive quiet time intervals. 93% of patients reported quiet time mattered to them. Now I will address questions related to credibility of this article. The study was in fact published in a source that required peer review. We determined this by going to the publisher's website. The design used was appropriate, but a randomized control trial would have yielded more credible results. The data obtained and the analysis conducted did in fact answer the research question, and the researchers were able to get enough data to support clinical change. The measuring instruments were reliable and valid because they had been previously tested and proven credible. Based on the exclusion and inclusion criteria, most of the extraneous variables and biases were controlled through this study. However, not randomizing the patients into control groups did compromise the study and made it so that some of the findings could be due to extraneous variables. More information about interventions is needed to make the determination about if they were consistently delivered, because as of now it only states that environmental stressors were reduced. Based on the information provided, each patient was treated similarly. A sample size of 129 is not high enough to determine if the results are statistically significant, and there is no evidence that a power analysis was conducted to determine the appropriate sample size was reached. No statistical difference was found because the intervention criteria was too broad and the patients were not randomly assigned to treatment groups. Other studies are not conducted on this topic yet, so it is unclear if these findings are significant. The researcher calls for more studies to be done in this area to determine if statistical significance does exist. Now I will discuss the clinical significance of the study. The target population was clearly described and further information was given on the inclusion and exclusion criteria that was used by the researchers. I think the fact that 93% of patients in the study said that quiet time was important to them is an important finding and is enough to signal a change in clinical practice. It also helped that the patients rated sleep higher and anxiety levels decreased over consecutive quiet time intervals. The level of evidence used in the study was 2B due to the fact that it was a quasi-experimental study with no randomization. The study was conducted well, but needed a larger sample size and random assignment, as well as a control trial to make the findings statistically significant. I felt the findings were credible due to the patient report that they felt decreased anxiety and increased sleep. Since there was no statistical significance to the findings, I would say that more research needs to be conducted in a better manner to make sure these findings are not just due to chance or extraneous variables. This study is relevant to practice because of the patient report that quiet time interventions should be implemented in hospitals, ICUs, even though there is no statistical significance at this time.
Every study in our findings table, except for the 6th study, found that both patients and nurses felt that the institution of quiet times reduced negative feelings and outcomes. The articles that instituted quiet times by reducing noise levels in the ICU were Articles 3 and 4 in our findings table. The literature from these 2 articles supported our PICO question. Both articles found that with reduced noise levels, delirium levels, patient agitation, were greatly reduced. The 5th article in our findings table differed from these 2 articles in that the implementation of earplugs was the intervention. The article found that cognitive impairment was reduced in 43% of the patients. The 7th article was interesting and supported our PICO question as well. It used a descriptive and quantitative analysis to determine the relationship between sound and the occurrence of delirium. This study found that noise levels interfere with the overall emotion of patients and their satisfaction. The literature review of this PICO question led us to believe that quiet time is an important intervention in critical care floor hospital settings.
Several recommendations based on evidence from the studies can be considered for implementation with adults in critical care units. One of the studies, Article 3 on our findings table, found that nurse satisfaction with quiet time was moderate to high, and another, Article 2 on our findings table, found that nurses reported quiet time as a valuable experience. These findings are favorable towards the acceptance of nursing staff towards implementing quiet times on their units. Clinical nurse specialists and leadership teams can individualize the use of quiet times to the needs of their unit and patient population using the following recommendations as guide. Recommendation 1. Institute quiet times, 90-minute periods, twice a day. Recommendation 2. Use noise reduction techniques by limiting staff socialization to break rooms and lowering noise of conversations during quiet time. Provide earplugs for patients immediately upon admission. Wear soft-footed shoes to reduce noise in the hallways. And reduce noise from machines by being quick to respond to alarms, including ventilators, patient call lights, and phone ringers. Less than 3-minute response time is most appropriate. Recommendation 3. Use stimulation reduction techniques. Turn out lights and close blinds in patient rooms, as well as designated areas outside of patient rooms such as the hallways. Cluster activities that are necessary for care during quiet time, but schedule procedures, blood draws, therapies, and treatments outside of the quiet times. Recommendation 4. Educate the patient and family on quiet time policies and the benefits, including the limitation of visitor interaction during quiet times. Recommendation 5. Use a unit-wide disciplinary approach and include all staff, including providers, registered nurses, patient care technicians, respiratory therapists, occupational therapists, speech therapists, physical therapists. Include all of them on the education of quiet time evidence and benefits. These recommendations will be most applicable in adult patients who are mechanically ventilated and have been admitted to the ICU setting within the last 12 hours. Patients would be excluded if under the age of 18, are pregnant at the time of arrival, are not patients in English-speaking countries, or if they have a Glasgow Coma score of less than 10. We would use the confusion assessment method for ICU for evaluation of intervention effectiveness.
In conclusion, our studies support the use of quiet time. This can be seen through the multiple benefits quiet time has on the patients in these particular settings. These benefits include less sedation for patients, a shorter duration of mechanical ventilation use, and a report of positive patient satisfaction. Since these benefits may seem inconclusive, we recommend further studies to determine the effects of instituted quiet time on delirium specifically. Our studies mainly consist of qualitative evidence rather than quantitative evidence, thereby limiting our results and findings. Though clinical significance was abundant, statistical significance was only found in a few of our articles. This is why we recommend further studies to be conducted on this topic. Further studies should include randomized controlled trials, which use power analysis for the sample, and include the target population with a relevant intervention. The setting should take place again in an intensive care unit. Extraneous and confounding variables will need to be controlled, and the study would need to be conducted by staff with expertise in the area. Based on the findings and results, recommendations can be made if the findings are clinically significant and credible.